Good afternoon to everybody, and welcome to Madrid, Spain. We are here at the Hospital La Paz, and we will appreciate you all attending this special meeting, and our special thanks to our international guest. The talk will be held in English, as you can see. And I would like to introduce Dr. Luis Guerreta. Luis Garcia Guerreta is the leader of the pediatric heart transplant here at the hospital, and he will begin the meeting. I must say that, as you can see, that there is open a question and answer section, so you can direct your questions, and they will be summarized both by Dr. Álvaro González. Álvaro González Rocafort is who leads the surgical side from the pediatric heart transplant here at La Paz, and he himself and Dr. Luis Garcia Guerreta will summarize every question. So thank you to everybody. I hope you will enjoy this interesting meeting. So Dr. Garcia Guerreta.
Hello, good afternoon. We're going to start with a couple of presentations that deal with heart transplantation and ventricular assist device in our country. This is the current situation of advanced heart failure in children in Spain, and we will talk in representation of all groups. So to make it simple, around 700 children are transplanted nowadays in the past few years in the whole world for receive a heart transplantation in the whole world in the past few years. 35% of them, clearly over 30% of them, need a mechanical circulatory support to reach the time of their transplantation. And that is why we're going to talk about transplants and ventricular assist devices. Nowadays, the outcome of pediatric heart transplantation globally, as is recovered in this registry from the International Society for Heart and Lung Transplantation, you may see that in periods, in the current period in purple and red, transplants outcomes are very good with small disease rate in the first year after transplantation, and survival is currently over 80% at 5 years and probably reaching over 75% at 10 years as registered here in this international registry. What happens in Spain? In Spain, we have a national registry, which is mandatory, and all heart transplants from the beginning of the first transplant in the country are registered. So we do in the country around 300 transplants, both in children and adults per year. And in the bottom of this slide in blue, you can see that the number of children transplanted is small. In the Spanish registry, children are considered those who are under 16 years of age. So as I was saying, the number of heart transplants in children in Spain is slowly growing, but numbers are not big. They're usually between 20 and 30 with a peak of 35 in 2018. You all know, and especially guests from abroad, that Spain has the highest organ donations rate in the world, which reaches almost 50 donors per million inhabitants. But most of these donors are quite old, as you may see in the next pictures, in the next slide. So here you see the age of heart donors in Spain, and in blue at the bottom, you can see that the numbers of heart donors, of children heart donors, is small, and over 50% of donors in Spain are over 45, which is, of course, quite old. In that sense, Spain performs around 7 heart transplants per million inhabitants, both in children and adults, but the rate for children is quite small. It's 0.4 transplants per million inhabitants, which makes those 30 transplants a year. There are 6 hospitals in Spain that perform heart transplantations. 2 of them are in Madrid. 1 is in La Coruña, 1 in Catalonia, 1 in Valencia, and 1 in Andalusia. The number of transplants per year and hospital is registered here. This is Hospital La Paz. This is Hospital Gregorio Marañón, both from Madrid. This is Reina Sofia from Andalusia, Valdebron in Barcelona. And as you see, the numbers of most are under 8 per year, and highest is usually Hospital Gregorio Marañón. And you may see global transplantation activity for each hospital. And nowadays, over 40% of patients reach transplantation with mechanical circulatory support, mainly with ventricular assist devices, and some still with ECMO. Waiting time for children, disregarding if it is an urgent code or an elective code, is usually over 1.5 months, 2 months, and in some years it has reached almost 121 days. Compared to adults, if adults in the country are in highest urgency code, they have a good chance of getting transplanted in a week. But in children, we usually have to wait for a couple of months. This is what we usually do. This in green is the number of patients that have been included in the transplantation list by year. In pink is how many of those are transplanted, and down at the bottom, how many remain listed at the end of the year, which is quite variable depending on the donation rate that year. These ones up here are in light blue, dead, or this connected from the waiting list because of getting worse or getting better. Survival nowadays, survival for the whole group includes 490 patients until 2019, and survival for the whole group is close to 75% at 5 years and 65% at 10 years. Per periods of time, we're doing much better lately. Here in the green and the yellow, and survival at 5 years is close to 80 or 82%, and that remains constant. And we're getting to have survivals of 75% at 10 years. Survival by diagnosis is worse for patients with congenital heart disease, here in red, compared to patients with cardiomyopathy, which happens also in the registry of the ISHLT. This, as you may see here, at 10 years of age, at 10 years of the transplant, survival would be 60% for this group and almost 80% for the other group. If we see if we analyze these two images, this one here shows the risk for children under 1 year of age, which is in blue, and as you see, they fare much worse, children under 1 than older children. And in this right side of the slide, we compare in green the children that reach transplantation with a mechanical assist device to children who are on elective code to transplantation, and both of them are much better, have much better survival than patients with an urgent code and without a ventricular assist device. This has been published the good impact of mechanical circulatory support on survival in our patients recently in this journal. In summary, pediatric heart transplantation in Spain is a growing procedure. Expected survival nowadays is around 80% at 5 years and 75% at 10 years. Newborns and infants under 1 and patients with congenital heart disease have lower survival rates. And long-term mechanical circulatory support has been key to prolong waitlist survival with similar long-term survival to left coat patients. Thank you.
Okay, perfect. Let's gonna start. I don't know if there is any questions here in the chat. In the chat, there is no questions by the moment. Any in the audience wants to make one question, or the rest of the speakers? I don't know if you would like to ask something to Dr. Gareta. No. Okay, Luis, just a short question because we are running out of time. Do you have noticed something, a drop in the heart transplantation program during this outbreak, COVID outbreak? Do we have less transplants, or we are doing more or less the same compared to the last year?
We have kept our programs open with only a short period of time in March that were closed. For children, most of the transplant programs have been open, but some have had to be closed for a short period of time. We have in 2020, at least in our hospital, we have continued with the same or more transplants than the year before, and adults for sure have decreased their numbers very, very much.
Okay, thank you. Any more questions? No? So I think that we can go to the next talk. Luis?
The next talk will be Dr. Gonzalez, which will give us a presentation of mechanical circulatory support in Spain. All groups from Spain have been very kind and have sent us their data, so we have been able to make up this global presentation from mechanical circulatory support in the country. So Alvaro, whenever you're ready, you can start.
Okay, thank you, Luis. Okay, first of all, I would like to thank Dr. Gareta for his kind invitation to give this talk. And also, I would like to make it extensive, my gratitude to Dr. Mendez Suso for his work in the database creation and management. And of course, I also would like to thank to all centers that have participated and have shared their data to complete this registry. As we have seen before, there are also 6 centers that have a bad program in Spain, the same that have a transplantation program. In the Spanish Pediatric Part Registry, we collected data from 2006 to 2020, a total of 100 bad runs were implanted in children under 18 years old. Median age at implantation was 29 months. And I think that is important. I want to emphasize that 1/3 of the runs were in children under 1 year of age. Regarding support, 62% were LVAD and 36% were BiVAD. 161 devices were used in these implants. 117 were pulsatile flow pumps, and the rest were continuous flow pumps. All of them were paracorporeal pumps. 36% of patients were on ECMO at the time of implantation, of PAD implantation, and median time post support was 30 days, with a cumulative time of almost 6,700 days. Time evolution per year of pediatric BATS implantation in Spain shows a wavy curve, as you can see in the image, with an ascending trend that is clearer in this slide, where we have the cumulative experience, and we can see that the experience has doubled during the last 6 years. This steep increase is also seen in the PREDIMAX registry published in 2019. Pediatrics BATS implantations by center shows some interesting things. First, Valle Brown Hospital, that is the red one, had a more intensive activity at the first half of the period. Reina Sofia Hospital, that is the orange one, did it more in the last 5 years. And centers in Madrid, La Paz y Gregorio Marañón, they are the blue and the green one, have had a steady evolution over time, with a slight increase at the end of the period. La Fe started this program 3 years ago. Diagnosis was cardiomyopathy in 71% of the patients, mainly dilated, and 25% of the patients had a congenital heart disease. 16% of those were single ventricle circulation, and almost all patients had a corrected defect prior BAT implantation. There have been 3 BAT implantation in heart transplants, 1 in acute right heart failure, and 2 in chronic rejection. Diving a little bit more on the device type on support, as we can see here, pulsatile flow with Berlin X-Core has been the preferred device use in both supports, LVAT and VIVAT, and also in both ventricles when it was used in VIVAT support. When only right ventricle was needed to be assisted, continuous flow pumps were preferred, and they were the only devices used. Sorry. I want to focus a little bit more on stroke because, as you all know, is one of the most important complications on BAT therapy. We have had 35 neurological events, 35%, mainly ischemic, with a stroke rate of 5.4 per 1,000 BAT days. And this rate was higher in children under 1 year of age, as is expected. Final outcome was transplantation in 64% of runs, with 26% of death on support. 3% of patients were bridged to another device. And surprisingly, these data seem to be better in children under 1 year of age, with 72% of transplantation in children with BAT at this age, and only 18% of death on support. Final outcomes in a 5-year period shows that transplantation percentage has increased a little bit over time, and the stroke rate slightly dropped during this period of time. In La Paz Hospital, we were very concerned at the very beginning of our program because we had an extremely high stroke rate. We introduced some changes. We changed our anticoagulation protocol, and we also had a more active pump change when we saw thrombus or clots. And also in 2018, we introduced bivalirudin therapy as proposed by the action group that we will see later. And with these measures, we drop our stroke rate to half, but we still have to improve further. Survival, Kaplan-Meier curves show a better survival in single support compared to BiPAP, and also we had seen a better survival in children under 1 year of age than older. What is more striking is that also in children less than 6 months old seem to do better in our series, despite all these differences were not significant. As Dr. Greta said, we the last 5 years we have performed in Spain above or 20 transplantation, transplants, heart transplants, and of those, almost 25% of children reach the heart transplant with a BAT, with a median waiting time of 36 days. So in summary, some take-home messages. The first one is the number of BATs is increasing rapidly over time, not only in Spain, but all over the world. Use of BiPAP support seems to carry worse results, so try to avoid it if possible. We didn't use any intracorporeal PAPs in Spain in this registry during the last year, so is our moment, our time to introduce this kind of support. Another one is after the introduction of action protocol in our hospital, we have seen that our neurological fate has improved in these children, so should all the Spanish centers adopt it. And also, in our experience in Spain, small children seem to do better. So how small is too small? I hope that Dr. De Rita can address this in his talk. Nothing else. Thank you very much for your attention. I think that it was time. I'm going to I'm going to keep, because I think it was time to Luis to introduce the questions or whatever. But I don't know if there is another question for me. Is there another question? The audience and
in the current situation, in which patients do you think you should implant an X-core Berlin heart in a young child, a Berlin heart or a Thoratec device, a continuous flow device versus Berlin heart?
In which situations? Well, I think that it depends on several things. First of all, if you expect that is going to be a very long support, obviously pulsatile flow pumps, I think that do better. But it also depends on the weight. Now, despite we have found these results in the registry, in our experience, we have had very bad results in children under 5 kilograms with Berlin heart due to neurological events and complications. So probably also during infection and in the first time of postoperative course, when we have to implant an assistation, that there is also an inflammatory state. Perhaps the use of continuous flow during that time could be better to manage anticoagulation and if it is necessary to make a pump change.
Another question that I would like to address is that question that you made to yourself. Is it time to start with new devices like HeartMate or hardware that children could be able to go out of the hospital? How do you feel about this, given your experience and the absence of experience with these devices.
Oh, we haven't implanted any one of them, and of course, I think that there is a learning curve that we have to learn how to implant it. I don't think that it differs very much from the implantation of a corporeal pump. But of course, I think that two things: so to go abroad to learn the technique, or we have to bring some surgeons here to show us how to implant it. I don't know if that was your question.
Yes.
Yes.
Thank you. So if there is any other question, I would stop, but I would like to welcome people from Boston Children's Hospital. We have with us today Dr. Paul Esteso, who is originally from Mexico and has been working for some years now in the transplant and VAD program in Boston. And he's going to talk to us about the action group, which is, he will explain, but it's a collaborative way of working among different centers to improve. So whenever you want, Paul.
Thank you, and thank you very much for the honor of having the opportunity to talk to you guys about the work that the Action Collaborative has been working on. And so I want to share with you this presentation about the impact of a pediatric collaborative on the rate of stroke during ventricular assist device support. And these are my credentials. I have no relevant financial disclosures, which is something that we have to say in the States. I don't know if you guys have to worry about it. So to tell you a little bit about what Action is, Action really is a group of people interested in fighting a common problem. And that common problem, as you guys well described in your own experience, is stroke in pediatric patients who are supported with ventricular assist devices. And this group is composed of members up and down the interested people involved in this, which includes nurses, families, industry partners, regulatory bodies, and physician partners as well. And what Action does is to pull data and outcomes, to share our experiences, our education, and an administrative content, and with the approach to leverage quality improvement sciences to approach pediatric heart failure. And just like in Spain, in the United States, every one center has few of these patients on a year-to-year basis. And in order to advance the field, we want to put our experiences together. With this in mind, our mission in Action is to improve critical outcomes for pediatric and congenital heart failure patients by learning together and advancing the field expeditiously. And what expeditiously means in particular, the reason I think it's an important word is because it means both quickly, but efficiently and astutely, and not just loosey-goosey. In other words, our mission is to steal shamelessly from each other and to share seamlessly. So it's not about being in your own silo and worrying about your data, but worrying more about the patients and helping each other. Just like you guys demonstrated, getting the VAD data from the whole country and putting it together in a presentation that helps you understand the current standing. So who is Action? This is a flow table of the leadership and the different areas in Action. And it is a bunch of people that are interested in helping kids get through this difficult period of treatment. It started in 2017 with 8 centers. And it started with people running VAD programs, texting each other and trying to learn from this individual small experiences and trying to make things better. It now is composed of 56 participating centers, including 7 international partners, 4 industry partners, and a bunch of families and patients who themselves take part in our meetings and in our design and in choosing what's important to us, what's important to them, and trying to do so in a collaborative manner. So what are the key efforts of action? And this is really 4 things in general. One is data collection. And this data is looked at frequently and in detail. It's adjudicated quarterly. It is also looked at real time for device-specific FDA and trial purposes. And we're also looking at multiple facets of advanced heart failure management. It is quality improvement, and we have multiple initiatives to try to reduce adverse events, improve care delivery and communication. And one excellent example of this is our first initiative, which was Berlin Heart Bivalirudin protocol to reduce pediatric stroke. It is education, and that means sharing pediatric specific bundles, and Action has leveraged our communications team, and they make excellent videos and excellent modules that we can happily share, and is also taking the opportunity to focus on relevant current problems like COVID-19. And it is a number of other network collaborations. And for example, we are looking at PC4 data, which is a pediatric critical care data set, and trying to link that and other relevant registries to try to increase the power of the data we are leveraging to try to answer these questions. So to look at the primary problem that got us together, we need to try to understand where we were coming from. And this is data from the Berlin Heart North American device exemption trial. And what you see here on that top graph is the types of neurologic injuries that they saw. And on the bottom graph is first the extent of neurologic injury and then the outcomes. And so if you look at the first line on the second graph, it says that patients had greater than one neurological event, one or greater than one neurological events at a rate of about 29%, which is very similar to the experience that you guys reported. If you look at what the types of strokes were on that upper graph, the majority of the strokes were ischemic in nature, with another big proportion of transient ischemic attacks, which we also think are likely thrombotic in nature. And if you look at the outcomes, patients who had a neurologic event died on support at a rate of about 40%, which is very high. This is data from PDMAX between 2012 and 2015, reflecting similar experience, where at a year post-transplant, there were 53% of patients who were free from a neurologic event, meaning about half the patients have a neurologic event on support by about 1 year. So with that understanding, Action launched the first QI project, which was really to reduce stroke on bad support. And in order to do that, we got together interested parties all up and down the scope of practice and experience, and came up primarily with the ABCs of stroke prevention, or these 3 primary interventions. The first intervention, as was briefly mentioned earlier, is focusing on anticoagulation. The data that was part of the original Berlin trial was primarily done on heparin, and that data has been recapitulated on warfarin and aspirin with a similar rate of neurologic events. There has been experience here in Boston and at other centers looking at direct thrombin inhibitors like bivalirudin, and we had demonstrated a lower rate of neurologic adverse events on bivalirudin. And as such, an Action came up with a protocol that we distributed broadly to share that experience and leverage that anticoagulation. It included standardization of initiating, monitoring, and adjustment of anticoagulation, as well as including timing for when to start antiplatelet treatment and when to treat with anti-inflammatories to reduce the risk of thrombus. And this is the document that we are happy to share. The B and the C of stroke prevention were blood pressure control, and that blood pressure control was primarily focused on continuous flow devices rather than pulsatile devices. and trying to have a way in which we're all standardly taking blood pressures to be able to communicate. And the communication, which I think has been a very important part of this intervention, is a daily rounding stroke prevention checklist, which is done at the bedside every time you see the patient, and where we talk about the current status of that patient, whether they're inflamed or not, what their current baseline neurologic status is, what their anticoagulation is, how often are you checking the pump, how often are you changing the anticoagulation, how often are you checking that? And it's across multiple disciplines, and it sets the whole team in the same page. And this graphic illustrates that in a sort of short in a short image to try to focus everyone on what's important to these patients. And as of 2019, for our annual action report, we had demonstrated that that rate of 30.1% was down to 12% in all patients supported with Berlin across action sites. And in 2019, we had 44 action sites involved. This is hot off the presses. We don't have the 2020 report yet, but our data that we just looked at, and this is data percentage of stroke on the left side, over time, quarterly on the right side, on the y-axis, sorry, on the x-axis. On the left side here, this is PDMAX data, and starting on 2018, this is action data. And what we see here is that by the most current data, this orange line is now 8.7%. Our stroke rate is well below 9% for patients supported on Berlin with this protocol. Our efforts continue to try to improve care of children with this approach. And it involves helping families understand where they are on their patient VAD journey, helping us leverage the data. And there's now interactive reporting where we can look at specific aspects of the data collection across all these centers. There's patient, family, and provider specific videos, training modules, video games, and infographics. And some of the infographics we've actually gone ahead and translated into Spanish, and we're happy to share these. And so for example, this is an infographic about COVID-19 and what does it mean to flatten the curve? How do you stay safe? How do you talk to your family about the simple things like wearing masks, washing your hands, and all that? So with that, we ask what's next, and we've set a new target goals for preventing stroke in action across action centers, and we've set a new target data of 30% reduction from our current less than 9% for all types of strokes on all types of devices. We're launching a number of initiatives that include looking at heart failure, looking at Fontan, looking at muscular dystrophies, and having similar interventions where we're all doing the same things across action centers to really leverage powerful data to make meaningful change. We have, at least in North America, a shared data use agreement and global IRB that allows us to share this data seamlessly and to be able to study it. And we also are able to use real world action data to expand VAD labeling in children. So that includes post-market surveillance of Berlin, which you've been seeing. And also we're expanding labeling on HeartMate 3 and HVAD to pediatric patients, as well as working on expanding the labeling for the Impella. And finally, we're leveraging action to really try to do device trials. And one example of this is the Berlin Active Unit, which is sort of the small version of the ICAS, and we're going to help run the trial through action. One thing that we'd love to continue to do is to expand international involvement in action, and for those centers outside of North America to really examine the feasibility of sharing data and be able to participate in QI, and to continue to identify all interested shareholders. So with that, I'm happy to have had the opportunity to share this data and happy to take any questions, as is Dr. Vanderplum, from you guys.
Okay, thank you very much, Dr. Esteso. I enjoy very much your presentation. I think that there is no question from the audience, so I have one question, and I think that it is an easy question for you. So I have seen that you have 56% international centers join. Do you think that it is interesting that the Spanish center can join to the Action Collaboration Group? And in that case, that I suppose that is yes, how can they do it, or how can we do it?
Yeah, so joining Action is easy, and I can share the information. I can send you guys emails, and you can distribute them among. We'd love to have involvement from all Spain centers. It certainly seems like there's an opportunity to improve the rate of stroke in your patients, and we'd love to be able to help with that if possible. The involvement in Action is easy as being interested and participating in our discussions and our projects. The thing that we will continue to have to work on is the data share use agreement. But you don't need that to be part of an Action center and to sort of benefit from our experience and us from yours.
Yeah, to Paul's point, we really are looking at expanding to get global participation. The reason being is, we have one way of doing things in North America, but that's not necessarily always the right way or the best way of doing it. And so we really want to look at what other centers are doing across Europe, across Asia, and start learning from their experiences. So as Paul said, there's different aspects with the registry, with the data collection aspect, and you guys have already collected data through a registry, but you can participate in just education. And one of the challenges of bringing intracorporeal devices is training everyone and having the educational content. And that's something that we've already developed. And so ultimately, we're happy to share that with you, and you can modify it for your centers. But we would love to get your input on what would work best for your patients. And at the same time, rather than reinvent the same content, just share what's already been developed. So as Paul said, we can definitely forward all the contact information and even set up a call at some point with interested parties to figure out how we can get centers from Spain involved on action committees that are of interest to you.
Okay, thank you, Cristina. There is one question from Dr. Menendez Suso from Hospital La Paz, and is for you, Dr. Vanderplum. Not two questions. The first one is about your experience with bivalirudin, and how long do you usually use it postoperatively, and if so, with which anticoagulant do you usually substitute it for long-term treatment? And the second question is, you are still relying on low-weight heparins or coumarin, or are you already using one of the newer oral anticoagulants like apixaban or dabigatran?
Yeah, those are great questions. So we have decided to primarily stay on bivalirudin for the duration of their support. We early in our experiences, we did transition some patients to warfarin, but we found in the one patient we did, he ended up having a stroke a week after we converted him to warfarin, and so we converted back to bivalirudin. Now, our wait list times can be weeks to months. And so there is a financial implication of having, bivalirudin is much more expensive. There's also the consideration that the child is attached to a line and is still tethered, and they can get line infection. So we have been actively looking at going to an oral agent. So just this last month, we actually trialed apixaban in one of our patients, and there wasn't any adverse effects. We ended up going back. We ended up going back to bivalirudin just because we were actually weaning towards recovery. And so we wanted an agent that we could turn on and off more easily since we were going to explant the device. But I think there is potential promise in using medications like apixaban in this population. We just need more data at this time.
Okay, thank you very much. We keep it in bivalirudin all the time with the BAT by the moment. Okay, let's go. I think no more questions. Let's go to the next talk. I don't know if Dr. Guerreta wants to introduce. The next talk is Fabrizio De Rita. Fabrizio is a surgeon at Fremont Hospital in Newcastle. His hospital is one of the 2 hospitals in Great Britain that perform heart transplant and implant ventricular assist devices. In children, he is a native from Italy and has an extensive experience in children and adult congenital heart surgery. And he's talk about the experience in BAT therapy in children under 5 kilograms or with congenital heart disease. Fabrizio, thank you.
Thank you, Dr. Gonzalez, for the introduction, and it's a real pleasure for me to be participating to this webinar today. And I want to thank Luis for the kind invitation. And these are my disclosures. And so I have the privilege to be in a center that, as the ventricular assist device practice, a significant part of the game. And this is the summary of our VAD activity in the Fremont Hospital since the beginning. And we have implanted to date more than 200 VADs in pediatric population for all the diagnoses, including congenital heart disease and single ventricles. And we also had a substantial number in small children group where the results are 70% VAD run survival in children less than 10 kilos. That means one out of 4 might not survive the VAD run. Going to the 5 kilogram or less group, the survival is lower and is about one out of 3 of these patients might not survive. So if I have to answer one of the very first question of my presentation, yes, I think we have had the possibilities to implant VAD in children 5 kilogram or less. But there are limitations, and some of these limitations are technical. And the first one I want to mention to you is the type of VAD, because we know that for this specific group of patients, XCOR is the only ventricular assist device that is certified for use in any size patient, basically, including newborns. And there are currently no devices specifically designed for mechanical support in congenital heart disease and in single ventricle. So we have to adapt what the market has given to us till now. So XOR is probably the only versatile pump that can be used in isolation or in combination and can be effectively implanted in all the congenital and non-congenital anomalies. But I'm afraid there are more limitations, and the patient size itself can be a limitation. I always ask myself if in a small child I'm able to fit even the Berlin pipes and connect it to a paracorporeal device. And I know when we talk about congenital heart disease, there are concomitant surgical procedures that needs doing to allow the VAD implantation, particularly in single ventricle anatomy. Most of these patients have previous operation or sternotomies. They might have developed collateral flows. They might be at an excessive risk of bleeding. And also they might experience already pre-VAD comorbidities with failing of the end organs. And they might not be great candidates for transplant because they became highly sensitized. And also there are some logistic limitations that are equally important when considering organ allocations and national rules. And currently in United Kingdom, the average waiting time for heart transplant in patients less than 5 kilos is approaching to 1 year of waiting time. And that's why NHS England stated some rules where 5 kilograms or less or single ventricle anatomy are a relative contraindication for VAD implantation at the moment. And if I want to implant VAD in a 4 kilos baby tomorrow, I need to obtain consent from a cardiothoracic advisory group and have national agreement for that. But moving forward, so to overcome technical limitation, the surgeons have introduced technical modification. And starting with simple things, in my practice, I always use extension on graft, so graft extension on Berlin arterial cannula, because I think it gives me more flexibility in the position and in the orientation of the pipe. And I found it particularly useful in complex anatomy. This is a CT scan of a baby post-posterior switch, where the long graft is absolutely necessary to reach the ascending aorta that is now posterior to the Lecomte maneuver, to the pulmonary arteries. And with that, we know that some of these patients might not be closed straight away after the VAD implant. This is a poor boy that required many days with the chest open. You might be able to appreciate the protruding and prominent Berlin-Hart arterial cannula through his chest, and he took many, many days to be closed. I've also found it very useful in other anatomies, like this is a CT scan of a baby, a small baby with pulmonary atresia, intact septum, that has been unsuccessfully palliated with BT shunts. So she was a single ventricle physiology, but we could support her with biventricular devices, Berlin-Hart, because we use the graft extended cannula to connect the branch of the pulmonary arteries to the outflow cannula. So instead of going over a univentricular assist device, we prefer to support her with biventricular assist device. Other centers have created different modifications, and this is a very interesting paper published by the Melbourne team recently about the use of X-core in infants. And they propose a technical modification about the LV apical cannula implantation to avoid inflow obstruction. This picture represents what should be the standard practice and orientation of the LV apical pipe in a normal size patient, but I actually propose to orientate the cannula a different way to avoid suctioning effect on the septum. And the rationale behind is that when you implant the LV pipe in small children, you create a sort of wedge between the diaphragm and the left ventricle that has been displayed now more superiorly and anteriorly, and this can cause suction effect on the LV apical cannula. So they propose a 45 degrees orientation of the pipe more towards the lateral wall rather than towards the septum. And in their experience, they had 14 infants, so less than 1 year of age, all with cardiomyopathies, none of them with congenital heart disease. They were all LVAD. The median weight was quite small, not all of them less than 5 kilos, but they had remarkably good results where the survival as bridge to transplantation with the device was 86%. Of course, they have experienced the usual and expected sort of comorbidities of VAD implantation. And moving forward, this is another very interesting experience from the team in St. Louis, United States, where they describe a novel surgical approach to mechanical circulatory support in univentricular hearts. And they collected 6 infants with hypoplastic left heart syndrome post-Norwood stage 1, where the median weight was quite low, 4 kilos. And the strategy was to avoid pulsatile pumps, but move directly towards continuous flow pumps, short-term continuous flow pump using the Levitronics. And the technical modification they propose is to use an arterial cannula rather than an atrial cannula to drain the right atrium. And the rationale behind is that the right atrial cannula has got a basket where clots might form, and also tissue of the right atrium of the tricuspid valve might interfere with the cannula itself and causing obstruction. So they found a better drainage, better inflow drainage using an arterial cannula. And as an outflow pipe, they've preferred to use an apical cannula with a graft extension connected directly to the reconstructed aortic arch. And that would have been in favor of a better alignment and prevent kinking of the outflow cannula. And the results have been remarkably good. They've been able to support successfully to transplant and to recovery, because you can see a couple of patients, actually 3 patients that have been successfully bridged to the next stage of the single ventricle palliation, to the Glenn stage. So with an overall survival of the VAD run of 71%. And I think is one of the good remarks is that they've been able to support for a prolonged period of time with a median length of 73 days that is definitely exceptional in this sort of circumstances and anatomical substrate. This is now the most up-to-date experience with the X-core in hypoplastic left heart syndromes, and it comes from the team in Gainesville in United States, in Florida. And their rationale is the use of a combination between a hybrid procedure for hypoplastic left heart syndrome and the VAD implantation itself. but in which circumstances? Just in babies that have been declared not suitable for the standard surgical palliation of the single ventricle. For example, they had patients with hypoplastic left heart syndrome, already with a moderate RV dysfunction and severe tricuspid regurgitation, where they felt that doing a normal procedure was an absolute contraindication. So the procedure consists in putting a stent plus minus, putting bilateral PA bands, and at the same time implant an inflow and an outflow pipe and connect Berlin-Art, connect them to an X-core system. So the VAD implantation is the primary operation. So I think the great advantage is that you have patients where you commit straight to VAD implantation as potential bridge to transplantation. So you avoid all the potential comorbidities that the patient would have acquired after a failing Norwood, for example. And in fact, the results are somehow good in the sense that first of all, I want you to notice the very long durability of these VAD runs. So all the patients have been supported at least for a couple of months with two of them with a very long VAD run. And 2 of these patients have been transplanted, 2 died, and 1 at the time of the publication was still on the support. And more recently, it's just actually in October this year, the same team have updated their results. Now the paper is not out quite yet, but I found some useful information online anyway with the abstract. So now the patient they've collected at 9, and 6 of them has been approached with the procedure, hybrid procedure and VAD implantation as described before. And they've added also 3 patients that have gone through surgical operation first, also like Norwood with BT shunt. And they've been able to successfully bridge to transplant 6 patients. So they got 6 survivors and 3 non-survivors. And I think, to be honest with you, the abstract doesn't clarify, but I think the results are generally affected by the fact that there are 3 patients post initial surgical palliation that probably were not in as good condition as patients that would have received the primary VAD implantation. Having said that, the authors have been able to demonstrate that during survivor group has less inflammation, has definitely better renal and liver function, and less requirement of transfusion compared to the non-survivor. And finally, I want to show you the results of this recent retrospective study that came out in 2018 in the European Journal of Cardiothoracic Surgery, and was based on data collected in the Berlin-Art X-Core registry. So the registry is led by the company and contains worldwide tracking of the weight, the diagnosis, the VAD type, and the final outcome. And so in this paper, the aim was to compare the results between 2 implanting era, one early era from 2000 to 2012, and a more recent era after 2012 till 2017. And among all the patients that have been collected, for the purpose of this talk, I can show you that in the group A, so children less than 5 kilos, there were 204 patients, and between 5 and 10 kilos, 633 patients. And while comparing the 2 era, the authors have showed that the survival has dramatically improved in both groups comparing the 2 era. So the less than 5 kilos baby survival has moved from 51 to 61%, that is statistically significant. And the same has happened for the children weighing 5 to 10 kilos. And this is now the table that represents the mortality rate and the predictors of mortality per weight group and surgical implanting era. And the multivariate analysis for the group A, we can still see that congenital heart disease, the need for ECMO before, and the use of the need of biventricular support were independently associated with increased mortality, but only in the implanting era 1, while are not significant factor in the era 2. And with regards of the group B, so children between 5 and 10 kilos, only BIVAD remained as a significant risk factor for mortality in both era 1 and 2. So to answer the key question, if the outcome of VAD implantation in small children has improved over time, the key findings of the paper have shown that the outcome of VAD implanted in less than 5 kilos babies remain inferior, has improved, but remain inferior to the other categories, and unfortunately carries more risk compared to the rest of the group category. But the weight itself should not be a justification to limit the use of a ventricular assist device. So these are my conclusion, that I believe it is feasible to implant ventricular assist device in these children 5 kilograms or less. It is also feasible to do it in children of that weight and with congenital heart disease, including the single ventricle. The body weight itself does not justify withholding VAD implantation. Nevertheless, low body weight and congenital heart disease still remain at higher risk for VAD implantation. Thanks very much for your attention.
Thank you very much, Dr. De Rita, for your presentation. It was very good and I enjoyed it a lot. I think that there is, I don't know, no, there is no question from the audience. I have one question for you. As far as I understood in your presentation, you are not implanting Berlin heart in children less than 5 kilograms, unless you have a permission of the cardiothoracic group or something like this, or I misunderstood.
Yes, it's correct. So whenever we have that size baby, we need to obtain approval at the national level. So as you said before, we are only 2 pediatric heart failure centers in the country. So we need to share the decision, make sure that there is agreement based on the data and the presentation of the patient. And then after the agreement, we need to bring the case to the cardiothoracic advisory group that regulates the transplant practice and transplant decisions, because it's also mandatory that whoever we put on a mechanical assist device is a candidate for heart transplantation. We are not really financed to put ventricular assist device as a destination. Of course, most of the time we're done as a bridge to decision, that's possible. But at the moment, given the current situation, given the shortage of donor organs, we need to go through this pathway. And that's why we needed to limit the amount of implantation that we have done in such a small group of patients compared the past. And so 2020, there has only been 1 Berlin heart implantation in a less than 5 kilos patient that, of course, she's still waiting for a transplant. She's doing well on LVAD 7 months after the implantation, and she doubled up her weight. But that's the only event in that group of category that has happened during this 2020.
Okay, one question from the audience, Ana Diaz from Sevilla. Thank you for your very interesting talk. What is your experience, if any, cannulating this small patient in the atrium? And second question is, have you had any problems with the development of seromas when using the graft extension when cannulating onto Berlin heart?
So yeah, we've been using the atrial cannulation technique for the single ventricle patient that we have supported. We have supported in total 8 single ventricles with a ventricular assist device, either at the gland stage or after the first stage of the palliation. And of course, we've used the atrial cannulation in some conventional anatomies, but for example, with restrictive physiology. With regards of the question of the seroma, we have experienced the problem with the seroma when we have started using the factory-made graft extended cannula from the company, but that product was retired after the evidence that was a seroma. That cannula was extended with Gore-Tex material and not with the Vascutec, that is the material that we currently use. But we have to make that extension on the table every time we do an implantation. So even before opening the chest, I prepare the graft extension on the cannula myself. And with that sort of graft, that is the graft you would use for any vessels replacement or for aorta or arch replacement, we haven't experienced any problem with seroma.
Okay, thank you very much. Luis?
I have one last question, short one. How many of those 26 patients that you were supported with intracorporeal pumps were sent home to wait for transplantation?
Less than 50%, I have to say. We haven't been very consistent with that, but it's a difficult position. Of course, theoretically, the intracorporeal pump gives you the advantage to discharge the patient, like happens for the adults. But the adults are very capable to look after themselves, and children, you need to go through program of education of the family, and they need much more support. It depends where the patient is coming from. As we say, most of our patients are not local, and managing them with big distances, even with an intracorporeal device, is not straightforward. So in the teenager group, we've been able to send them home, almost all of them, but the few small that we did, so in that group between like 5 and 8 years of age, it hasn't been real possible. But you could reintroduce them to a sort of normal routine. Some of these patients have been able to go to local school here and then be admitted in the hospital, or at least in flats, in accommodation, hospital accommodation. But managing from long distances is not straightforward. You need to have infrastructure in place, nurses, personnel that would be able to look after them out of the hospital.
Thanks. I think we're running a little short of time, so I'm going to introduce next talk. Next talk will be given by Dr. Oskar Gonzalez from La Paz, and he has been a fellow in Newcastle with their team, and he works with adults, congenital heart disease patients and transplantation in this hospital. So Oskar, whenever you want, you can start.
Thank you, Dr. Guerreta, for the invitation, and good evening, everyone. I'm going to talk about severe heart failure in the young adult congenital, and I have nothing to disclose. So just to start, as you all know, due to the improvements in the care for patients with congenital heart disease, nowadays more than 90% of children born with a congenital heart disease are expected to survive to adulthood, and a big amount of them will develop heart failure in adulthood. According to the different series, up to 40% of them will develop heart failure. And heart failure is considered then to be the main cause of death in congenital patients, being between 25 to 35% according to the different registries. The incidence of heart failure increases with age in congenital patients. And there are many causes of heart failure. We may have intrinsic myocardial dysfunction, but we also can suffer from volume overload, pressure overload, pulmonary hypertension, systemic hypertension, coronary artery disease, and arrhythmias. As you can see here, the heart failure spectrum in congenital heart disease is quite busy, and we have 4 different groups. The first would be the failure of the systemic left ventricle. And in this group, we include patients with aortic regurgitation or stenosis, mitral regurgitation, and coarctations of the aorta. And we have patients that present with signs of left heart failure. They may have pulmonary edema, and also we can see a deterioration in their functional capacity, and sometimes they have arrhythmias. The second group of patients would be the failure of the systemic right ventricle, and we include in this group patients with a congenitally corrected transposition or transposition after an atrial switch procedure, such as the Senning or the Master procedure. And these patients present with signs of left heart failure as well. They may have pulmonary edema, a clinical deterioration in their functional capacity, and as well arrhythmias. The third group of patients would be the failure of the subpulmonic right ventricle. And in this group, we have patients with a tetralogy of Fallot, Epstein patients, pulmonary valve abnormality patients, and pulmonary hypertension patients. And this group will develop signs of right heart failure, arrhythmias, atrial or ventricular, and they may develop cyanosis and progressive desaturation. And the fourth group would be the Fontan failure. This group is quite different, and these patients have different clinical presentations. They may have signs of right heart failure, sometimes left heart failure as well. They have arrhythmias, and they have some different entities, such as the Fontan-associated liver disease, the protein-losing enteropathy, and the plastic bronchitis. So we have challenges in order to identify heart failure in congenital patients because our patients do not present with typical symptoms, and it's difficult then to detect heart failure early. Symptoms are not often reported, as these patients do not view their limitation as something abnormal, and they are used to cope with different symptoms that they not relate with a worsening in their prognosis. So we need to do objective tests such as cardiopulmonary exercise testing in order to do the evaluation in these patients and see if there's a change in the functional capacity. So it's essential that congenital cardiologists work closely affiliated with heart failure cardiologists in order to take care for the failing patients with congenital heart diseases. So in order to the assessment, these patients have to be early referred to specialized centers where we have multidisciplinary teams of congenital cardiologists, heart failure cardiologists, transplant and congenital surgeons, and some other members and physicians that are able to assess these patients in order to identify heart failure in its advanced stages. So in order to manage heart failure in these patients, the first thing we have to do, if possible, is to palliate or repair the lesions, but sometimes it's not possible. In patients with symptoms with functional deterioration of the ejection fraction, we can start heart failure medications such as RAS inhibitors, beta blockers, MRAs, and diuretics, but we need to know that these patients can fail in the future, and they may need, when they have refractory symptoms, advanced therapies, and we need to stratify the risk for sudden cardiac death in order to indicate devices. When we cannot do advanced therapies for our congenitals, we need to take into account that we can have palliative care in order to improve the symptoms of the patients. So regarding the devices, the ICDs, as you all know, are indicated as for secondary prevention in survivors of sudden cardiac death, in documented VTs or inducible VTs in the EP studies, but we can indicate these devices as well in primary prevention, in systemic left ventricular ejection fraction less than 35 and functional deterioration with an EHA class of 2 or 3, in patients with a tetralogy of Fallot and high risk scores for sudden cardiac death, and in patients with systemic right ventricular dysfunction in the presence of risk factors such as VTs, functional deterioration, or severe systemic AV valve regurgitation. We can use cardiac resynchronization therapy, and we have to use these therapies as they are indicated in patients with impaired systemic ventricular ejection fraction and NIHA class 2 or 3 and wide QRS duration. As you all know, heart transplant is the gold standard for treatment of these patients, and it remains the surgical procedure of choice for eligible patients with severe advanced heart failure. But congenital patients have some challenges when we talk about heart transplantation, when we compare our patients with acquired heart failure. These patients may have pulmonary hypertension, they have a higher prevalence of HLA antibodies, and the anatomy could could be very complex with previous surgeries that may difficult the transplantation. And also we need to consider that the patients with a single ventricle physiology have worse outcomes and some peculiarities that we need to take into account. So due to these challenges, there's a contraindication sometimes for a heart-only transplant, and we need to think about combined transplantation if possible. As well, the waiting list time could be higher than in acquired heart failure patients, and the outcomes sometimes are worse. So we need to assess the patients early, because if we get very late, we may develop different complications. And when we have more organs involved, the risk and the mortality risk is higher after transplantation. And as I said before, the patients with a single ventricle have a higher risk of having these complications. As you can see in the International Registry of Transplantation of the ISHLT, in the last report, there's a higher incidence of congenital heart disease when we talk about the rates of transplantation due to the advances in the past few years in the treatment of newborns with congenital heart disease. And the results of transplantation with a congenital heart disease are worse at the beginning because they have a higher mortality during the surgery and in the first few weeks, but after that the risks equals the rest of etiologies. And when we talk about long-term in transplantation, congenital heart disease patients have better survival when compared with ischemic or dilated cardiomyopathies. The Fontan patient, as I said, is a special type of pathologies, and we need to know that we can have involvement of other organs such as the lungs, the vessels, the peripheral veins, the kidneys, and the liver. And we need to know that Fontan patients may develop some complexities such as the protein-losing enteropathy that requires specific medical treatment. And if it's refractory to medical treatment, could be an indication for heart transplantation. And most of the patients will develop some degree of Fontan-associated liver disease. So in Fontan patients, we need to be very aggressive assessing for liver disease in order to identify candidates for a heart transplant alone, or candidates with advanced stages or cirrhosis or fibrosis in the liver, where a combined heart and liver transplant could be a better option. I'm not going to talk about this because it's going to be the main topic of the next talk, I guess. So when we talk about survival in the Fontan patients, the survival is worse than compared to other groups of congenitals, and we have a mortality risk of 30 to 35% in the first year after transplantation, which is much worse than the survival that we have when we have a biventricular physiology. Regarding mechanical circulatory support, it has been talked before in different talks, but we need to distinguish between a short-term support with Centrimag or ECMO and long-term support in congenital patients. We may use different devices such as the total artificial heart, the hardware device, or the HeartMate 3. And we indicate MCS in adult congenitals who have end organ dysfunction or when they have elevated pulmonary vascular resistances before a heart transplant, when we indicate these devices as a bridge to transplant or a bridge to candidacy for potential candidates that are not eligible at the moment for transplantation. But there's been an improvement in the results in the last few years, and some groups indicate some devices as destination therapy. The outcomes of MCS in congenital patients are a bit worse when we compare these outcomes according to the Intermax registry with non-congenitals, but the survival is quite good in adults at 2 years, more or less 60 to 65%. There's a specific subgroup of patients, which is the systemic right ventricular failure, where the durable MCS can take a role. And there's an increasing population in the past few years with systemic right ventricular failure, and the use of VATS has increased. Ventricular assist devices in these patients has proven to reduce the pulmonary vascular resistances, and there have been published different series of patients from 1999 with the first patient and some different series, such as the group of Newcastle implanting VAT in these patients with good outcomes. There are two peculiarities that we need to take into account. The position of the cannula, the place of implantation is in the right ventricle free wall, and the pumps are usually designed to be implanted in the apex of the left ventricle. So we need to position the cannula well, and we may damage the subvalvular apparatus when we do the surgery. So there's a potential role of the residual tricuspid regurgitation, and in patients with significant tricuspid regurgitation, as the cannula is not fully aligned with the systemic AV valve, we may need to perform during the surgery a valve replacement as well. The last but not least is the end of life care. Sometimes we don't see that our congenital patients have a progressive heart failure and they have a high risk of premature death, and only a minority of them had engaged end of life discussions. So different surveys show that the majority of patients are willing to participate in advanced care planning, but most of cardiologists don't believe that they are ready for these conversations. But it's important that palliative care specialists work together with the heart failure teams in order to address the unique needs that our congenital patients may have. So in order to finish my presentation, I would like to make some points. Heart failure is a common problem in congenital patients and is considered to be the main cause of death in adult congenitals. So we need to recognize symptoms early, because the recognition of heart failure symptoms might be difficult, and it has an impact in prognosis. Patients should be referred to specialized centers, and we need to make close collaborations between congenital cardiologists, heart failure cardiologists, transplant surgeons, and congenital surgeons in order to manage well these patients. Advanced heart failure therapies are effective treatment strategies for selected congenitals, but we need to know that these congenitals have additional challenges that we may need to address in order to have good outcomes. So we need to do a comprehensive evaluation of our patients, and especially in the subgroup of failing Fontan, as we need to do a full assessment of the liver in order to identify candidates for a combined heart-liver transplant. Mechanical circulatory support has shown to be a successful strategy in congenital patients, and especially in the subgroup of patients where with systemic right ventricular failure, where it is effective as a bridge to transplantation and bridge to candidacy. And we need to know that our patients should participate when needed in advanced care planning involving palliative care teams when needed. So thank you for your attention, and I'll be happy to take any question you have.
Thanks, Oskar, very much. I would like to ask you a difficult question, or how important do you think are the surgeons how important do you think is a congenital heart surgeon in a transplantation team? Or how important is a transplant surgeon in a congenital team?
Okay, so I think I don't know if you want to say that how important are congenital surgeons for congenital transplantation. I think this is what you want to ask, isn't it?
Yes.
Okay, yeah, so I think it's very important, because as I've said, there are many challenges, and these patients usually have 3, 4, 5 prior sternotomies, And the importance of having a congenital surgeon that is used to work with these patients. They sometimes have very difficult anatomies, and as you can see, as I've shown before, the results in the first weeks after transplantation are worse when we compare these patients with other etiologies, and this is mainly because of the surgical challenges. So I think it's quite important that congenital patients are have congenital surgeons to do transplantation, because they are used to work with these patients, and they know the specific needs that they have to address with them.
Thanks very much. I think we should move on to next talk. Next talk is, following this talk is another extension of the talk, and it is Lig Reason's turn. Lig is a pediatric cardiologist, and he works with adult adult congenital patients. He works in LA, and he works at the place where Dr. Perloff, who invented this adult congenital specialty, worked. And in his center, there's a lot of commitment to adult congenitals, and he is the leader of transition care. And he is going to give us a talk in combined heart liver transplantation, where they have a good experience. Thanks, Lig, whenever you want.
Luis, thank you so much for that kind of introduction. We really enjoyed your visit here last year. And as everybody should know, he was a lucky charm for us, because we got a lot more heart transplant offers when Luis was here in Los Angeles visiting us. So we desperately miss you. Thank you so much for inviting me. And Dr. Gonzalez, thank you for such a great introduction to adult congenital heart disease and the challenges for transplant. One of the beautiful things about this virtual world is that I can adjust my talk as I'm listening to yours. And it was such a great introduction, because I think one of the ultimate destinations and one of the struggles that we really find ourselves in is the combined heart liver transplant patient with a single ventricle physiology. And now Dr. Gonzalez already sort of mentioned, you know, the profound changes and risks that come along with doing transplants in Fontans. And that goes back to sort of seminal papers by Jackie Lamore back in 2009 that showed this sort of steep fall off of survival, particularly in the early period for patients who are single ventricles. And so, you know, I think a lot of these patients, these were both from a registry of both some adult patients, but mostly pediatric patients. And one of the things that they really noticed was that bleeding was a main reason for compromise, as well as infection, and just surgical complexity also played a big role in patient outcomes. And, you know, at UCLA, we have, you know, the history of Dr. Perloff, as you mentioned, and we kind of saw a difference between our adult congenital patients and our patients who were pediatric in terms of their survival. And we actually went back and we published our experience looking at about a 15-year history of transplanting patients with single ventricle physiology. And over that 15 years, we had transplanted about 20 patients, and we had no mortalities that were early, and we had a single mortality at 3 years due to coronary artery vasculopathy. And, you know, we kind of were curious why that was. And I think that one of the struggles is trying to figure out the granularity. Is it systems based? Is it selection based? And we just don't know. And I think that's one of the things that we're all trying to learn and trying to figure out is why do some patients succeed and why do some patients not succeed? And when we looked at our cohort, we had about 50-50 in terms of male, female, and our average age of transplant in this adult cohort was about 30. And we had started doing more combined heart liver transplants around 2015. And so in this cohort, we had about a quarter of our patients got a combined heart and liver transplants. And what I think we learned, we had sort of adopted Fontan conversions for a lot of our older Fontan patients who were having a lot of arrhythmias, and we had almost a 20% mortality with the Fontan conversion, as was seen at a lot of other centers. And so I think we began adopting a heart liver transplant for people who had Fontan-associated liver disease a little bit earlier. Now, these first patients were very much a struggle for us. You know, we had patients, our first few patients stayed in the hospital post-transplant in the 76-day range, but the median was, you know, 51 for patients who were combined heart livers, and our patients who were just hearts alone, the median time to discharge was 23 days. And while these were long, arduous tasks and holding these patients' hands daily to get them through, we didn't have a whole lot of long-term bad outcomes. And just here's some of the short-term ones. We had to have a couple patients had to go in for chest re-explorations for bleeding. And again, we had no deaths. And then our long-term outcomes were actually pretty good. We didn't have a whole lot of bad outcomes. And again, we don't really know exactly why that is. And what we're trying to learn over time is trying to figure out what that is. And now there's other centers that have been doing amazing work in this field as well. And Stanford published their experience with 9 heart liver transplants between 2006 and 2018 recently. And they also had a similar survival of 100%. Now they really detail an en bloc approach to their heart liver transplants, where they have both surgical teams, the liver transplant surgeons and the heart transplant surgeons, working together in one very crowded field. But they have had phenomenal success up there as well. And we tend to do ours in a sequential fashion. Now, similarly, our colleagues at Penn have published their experience. They looked at about 17 Fontan referrals. They were actually able to list about 10 of those patients, and 7 of them went for heart and livers. Now, the post-transplant hospital stays were a median of 29. They didn't detail the difference between the hearts versus the heart livers, but they also had no mortalities and a median of 4.6 years. And it's really hard to quantify, again, why there are some of these successes. And I want to share with you a registry that our colleagues at Columbia, Matt Lewis, has been putting together so that we can better understand this. Now, just to give you sort of a sense of what we've done and what we've learned since we published our experience back in 2018, we've done an additional 8 Fontan patients who've had heart liver transplants. We had 1 perioperative mortality because we chose to do an en bloc transplant. So there was something new, and then the patient had extensive bleeding. And unfortunately, she did survive for several days post-transplant, but she ended up having a brain bleed, and the family decided to withdraw. And surprisingly, a lot of our days to discharge after heart liver transplants really started to shrink. And I think as we started to refine our process, maybe we found some pearls, but every time you have a success, you always have a step back where maybe you have to reevaluate what you're doing, or you have something you didn't quite anticipate. So the next 7 of our transplants who had combined heart livers, we had discharges at 17, 21, 24, 13, 16, and 36 days. And our most recent transplant is still in the hospital. So that's why you see 60 plus. Now, Matt Lewis, as I mentioned, at Columbia, has been putting together a large registry of Fontan patients who have both just been referred for transplant and who have actually undergone transplant. And one of the interesting things that he's found is that there's also, there appears to be a survival benefit if you end up going for heart versus, going for heart liver versus heart transplant alone. And on the left, you see the Kaplan-Meier curve for an unadjusted data. And then on the right, you see a sort of matching. My apologies for the typo there. And so that was controlling for time or era of transplant, as well as age and a variety of other factors. So I think there's going to be some really interesting data coming out of this big registry. We contributed to it, so did a lot of other centers from all over the country, and really hoping to find some granularity. I think there were 175 data points within this registry to enter for each patient in REDCap. So again, I'm hoping that we kind of learn more. And I think one of the biggest issues that we really struggle with is when do you make that choice between a heart versus a combined heart liver? And as Dr. Gonzalez talked about, I think early referral, continuous Fontan surveillance from pediatrics to adult congenital, and looking for signs of Fontan-associated liver disease. We have a yearly sort of protocol where we check liver ultrasounds, hepatic function tests, AFP. We try and do a advanced liver imaging with EOVIST and MRI at least every 3 to 5 years. And then anytime a patient goes for a surveillance cath or a catheterization for another reason, we always get a biopsy. And then we have a comprehensive review by a multidisciplinary team. That graphic that Dr. Gonzalez showed earlier, it really takes a large number of specialized people coming together and reviewing every case in depth. We probably spend an hour to an hour and 45 minutes on every patient that has been referred for heart transplant and try and decide whether or not they're appropriate for either heart or heart liver transplant. But the decision between heart and heart liver really hinges on the biopsy, the stigmata of liver failure. All patients have to have an EGD, they have to have their spleen evaluated, and then we really rely on our transplant team. And this is some unpublished data that I'm currently going through with some of our pathologists. And what we're actually looking at is the biopsy from the catheterizations and looking at it and comparing it to the explanted livers. And what we see on the left here is the liver biopsy from surveillance caths, and then on the right is the explanted liver. And in almost all of them, we came pretty close. There was one that was upstaged, and then one where the pre-transplant biopsy was insufficient. Again, a similar graphic that Dr. Gonzalez showed. It really takes a whole group of specialists in the same room sort of thinking about these things and then making these decisions. Now, once we've made a decision to list somebody for a heart and liver transplant, we really strive to make sure that they're optimized. So we actually admit our patients once they've been listed and once they're ready, and we put them on inotropes, usually milrinone and a little bit of dopamine, and then we do meticulous daily volume management. We have a PICC line in them, we measure CVPs every day, and we try and maintain them within a range that optimizes their hemodynamics. Also, we try and make sure that their kidney function is optimal before we go to transplant. Again, also before listing, we do a aggressive coiling of collaterals, and that's really probably the major practice change that we've made in the last couple of years, is that Dr. Van Arsdale, who is our surgeon who's been here for a couple of years, really noticed that if we were more aggressive with coiling collaterals, that his surgical field was a lot less bloody and he had a lot less return to the suckers. And so he felt that reduced the number of transfusions. We're also working on a manuscript for this as well to quantify these things. And in doing so, we're really changing the course of the intraoperative period. We've also sort of narrowed the donor distance window to no more than 300 miles or 480 kilometers. And then we do a lot of intricate attention to donor size matching. We calculate PHS or PMS, and we have the liver, heart, congenital teams, and everybody get on the donor evaluation call. So it's not left to just the heart transplant attending on call with the surgeons. The surgeons, as a point that was made earlier, we always have all of our transplants done with a congenital cardiac surgeon, as well as a specific liver transplant surgeon. If either of those team members are not available, nor some of the other key team members are not available, then we actually make the patient status 7 and wait until they are available. I think that when you have a misadventure, it's because your structured team isn't necessarily available. We also, sort of stepping back to that preoperative management, we have a pre-transplant sort of meeting talking about all the intricacies, all the venous connections, all the things that will need to be achieved during the transplant before we go into it. And that includes the perfusionists in the room. We have the liver transplant anesthesiologist, the cardiac transplant anesthesiologist in the room. So we have the entire team in the room and we discuss each patient before they're listed. And then one of the other things that we've done more recently is that we maintain bypass support during the liver transplant to rest the heart. The downside of that is oftentimes we get some vasoplegia and a lot of bleeding, and needing to really provide some interventions for that. The patients usually come back to the ICU intubated with their abdomens open, and the connection of the bile duct occurs about 24 to 48 hours after transplant. And then post-operatively, we have a dedicated team of anesthesia critical care attendings who are in-house 24 hours a day. We continuously update the plans. We have rounding both in the morning and in the evening to make sure that we're continuously moving forward. We have daily multidisciplinary meetings where all the team members are available to make sure that we're moving forward. We maintain a low CVP early, and the congenital team continues to stay involved post-transplant. And this is particularly important when we're talking about biopsies and surveillance and venous reconstructions and making sure that we don't have complications, particularly at the anastomotic sites at the liver. We've had one case where we had some stenosis where the liver anastomosis was, and we've had to go in and balloon that. And we've been really careful to be measuring IVC pressures as well as SVC pressures pre and post transplant, and making sure that we're not seeing a lot of changes in those pressures. And then the final thing we do is we do a full 360 review of the case. Did we make good decisions pre-transplant? Did we make good decisions about listing? Did we make good decisions intraoperatively? What could we have done better? And then post-operatively as well. And our comprehensive case reviews take about an hour to 2 hours, and we go through every single detail with the entire team. So I think these are the things that you can't really quantify. They're sort of the intangibles, but it's been really nice to take a moment and sort of share our process with you. And I'm happy to take some questions.
Thanks a lot, Leek, for your wonderful presentation and your kind comment about my visit. And I would like you to tell us in length of time, how long is a heart liver transplant?
So I would say on average, they've been averaging about 16 hours.
So,
Yeah.
and that's a lot.
It's quite the marathon. And the nice thing, I think the
Yeah.
important thing too, is that the cardiac surgeon doesn't leave. It certainly scrubs out on occasion and leaves the bypass going. And we probably support it, provide bypass support of, 1 to 2 liters, not a huge amount, but just enough to take some of the pressure off the myocardium.
So have you admitted many patients with failing Fontan physiology because they were rejected from other centers because they were not doing a heart liver transplant?
Yeah, so it's interesting. Most of our patients up until about 1.5 years ago were mostly from Southern California, and we are now primarily transplanting people from other regions of the country who have been declined at other centers. And one of, I think, the things that is a struggle is that coiling of collaterals that I talked about. It's a fair amount of radiation. It's very tedious for our interventional colleagues. We usually have to do them in 2 to 3 visits to the cath lab. And at the other institutions, their interventionalists have not felt that was worth, the climb. But, our surgeon is very convinced that this is really changing his surgery and his ability to provide good care to these patients.
Yeah. Thanks a lot. I guess that it involves different centers, but do you have a common liver transplantation team for children and adults at your hospital?
So we don't. The liver transplant team that operates on the adults will transplant down to about age 13 or 14. Younger than that, it's a separate team of pediatric liver transplant. We haven't done a whole lot of heart liver transplants in prepubescent children recently, although we have 2 that are currently listed. So we'll see how those are going. See what we've learned. What we've noticed is that Our peds interventional colleagues now come and show the angios to our adult congenital interventionist just to make sure that he feels that we've gotten every collateral that is necessary to get. And we don't coil the venous collaterals until the patient is considered listable, because we don't want to increase the Fontan pressures if for some reason they're not going to proceed to transplant.
I see a question from Dr. Gonzalez, who says, do you treat Phenovenous collaterals before transplants as well as arteriovenous collaterals?
Yeah, so those are the last ones we do. We actually admit the patient right before they're ready to be listed, and we coil all the venous collaterals at that time, and then they're kept in-house and listed. But they may have had their arterial collaterals already coiled in the weeks and months preceding.
Well, thanks a lot. I think we'll have to move on. Have a good day, because it's still morning there, I suppose.
Yeah, thank you so much.
We're getting into evening. Thanks a lot for your participation in our meeting. So, so now we will move on to Dr. Labrandero. Dr. Labrandero has been working with me side to side for many years. And he's one of the pediatric cardiologists here. And he belongs to a team that has put up a kind of strategy for neuromuscular diseases at the Spanish Society of Cardiology, taking into consideration their muscle disease and their heart disease, and he's going to talk to us about that. Go ahead, Carlos.
Hello, good morning, good afternoon, and good evening. Thank you, Dr. Gareta, for the kind introduction, and thank you to the organizers. As you see, we are moving now to another topic, hopefully interesting for all of you at this time, the neuromuscular disease. Neuromuscular disease encompasses a broad spectrum of diagnosis with different cardiac involvement that represents a major cause of morbidity and mortality, and the management of this cardiac condition is challenging. The most common cardiac involvement consists in cardiomyopathy and conduction defects with arrhythmias, and they are usually detected from childhood to the second decade of life, but it could also remain asymptomatic until later in life. However, the progression and the onset of the cardiac disease are dissociated from the skeletal myopathy. Although there are many types of neuromuscular disease with cardiac involvement, in my presentation, I will focus on the Duchenne muscular dystrophy, the most common form of childhood muscular dystrophy with cardiac involvement, and Becker muscular dystrophy. Duchenne dystrophy manifests as progressive muscle degeneration and weakness with symptom onset between ages 3 and 5 years. And Becker has a milder and variable phenotype with symptom onset from childhood to as late as the 6th decade. Both could have dilated cardiomyopathy due to dystrophin protein deficiency at the myocardium level. And in Duchenne patients, it's the primary cause of mortality in more than 20% patients. In Becker, the 70% of patients have heart failure by age 40. As survival and neuromuscular function in Duchenne muscular dystrophy improve with glucocorticoid therapy and respiratory advance, the proportion of cardiac death is increasing. Little is known about the use and the outcomes of advanced heart failure therapies in Duchenne dystrophy. These authors reported a retrospective cohort study of 436 males with Duchenne from 2005 to 2018, conducted at 17 pediatric hospitals across North America. The primary outcome was the use of advanced heart failure therapies, including implantable cardioverter defibrillator, left ventricular assist device, and heart transplantation. And here are the results. 43 patients had severe left ventricular systolic dysfunction. Of these, 12 died during a study period at a median age of 19 years old. The cause of death majority was respiratory failure, followed by sudden cardiac death. In 9 patients, an ICD was implanted. 4 patients received left ventricular assist devices, 2 hardware and 2 Hermate 2. The goal of left ventricular assist devices was destination therapy in 2 patients, bridge to decision in 1 patient, and bridge to transplant another patient. Destination therapy in children. Are we ready to this? This article reviews the current trends in the use of destination therapy and ventricular assist device and adverse events in children. PDMAX, the pediatric arm of the INTERMAX, included 508 devices in 423 patients below 19 years. The majority, 62%, had a diagnosis of cardiomyopathy compared with 20% of patients with congenital heart disease. The majority were left ventricular assist devices. The primary indication for BAT in children was bridge to transplant, 55%, bridge to decision, and only a minority of patients, 2%, underwent BAT implantation as destination therapy. Why not destination therapy in children is a question we could have. Pediatric programs may be reluctant to predestine destination therapy as a device strategy because there is limited experience in long-term VAD support of pediatric patients, and they have deal with different problems as patient device mismatch. And it's very frequent the need to create implantation strategies, especially in complex anatomies, and of course, alterations in the optimal flows could appear. Again, an analysis of the PDMAX focus on outcomes in children with hardware. They most frequently intracorporeal devices used in children, so that survival in children is similar to that of young adults with hardware. The long-term survival data are limited because the majority of the patients were bridged to transplant within 6 months of implant. The event rate for bleeding and neurologic dysfunction was high in children. In this table, we could see the sample criteria for destination therapy BAT support, and the potential DT candidate should include a reasonable success rate of survival in the peri and postoperatory stage, and a high likelihood to discharge out of the hospital with an adequate caregiver support. And there are several factors that preclude destination therapy as significant comorbidities like dialysis, contraindications for anticoagulation, and severe cognitive impairment. Also, complex anatomy not suitable for device implantation or device driveline exit site. This group from the Benvenue, Jesu, Rome reported their experience related with left ventricular devices as destination therapy in patients with dystrophinopathies. We could find here 7 patients, all with an age between 15, 16 years old, and of relevant. There were no in-hospital days. Of course, there were late complications for stay alive during the follow-up. And they conclude, these authors, left ventricular assist devices as destination therapy in children with dystrophinopathies with end-stage dilated cardiomyopathy is feasible and may be suitable as a palliative therapy for the treatment of these patients with no other therapeutic options. But LVAD only for Duchenne's patient. Here we have a brief report of a 14-year-old boy with a severe form of Becker dystrophy who developed a dilated cardiomyopathy with advanced heart failure in spite of maximal medical therapy, including high doses inotropic, and a Howard was implanted. As you know, the advantage of the Howard, the small size, and the intrapericardial placement is very important in this kind of patient to preserve the diaphragm function. What about devices in dystrophinopathies? This group from Italy reported a retrospective analysis of 18 dystrophinopathic patients, Duchenne, Becker, and also carriers with ICD or CTRCs. Also, 6 patients died during follow-up, respiratory and heart failure. At least 25% of patients fear subjective improvement in their quality in their daily activities. Unfortunately, no established standard of care for medical or device interventions are still available. As the role of destination therapy in Duchenne muscular dystrophy is unclear and controversial, these authors create a model to compare survival, cost, and quality-adjusted survival between medical management and DT-BAT with advanced heart failure. And DT-BAT versus medical management, DT-BAT was higher cost, higher survival, and higher quality-adjusted survival, but the effectiveness between DT-BAT and DVT-BAT in adults with heart failure in absence of Duchenne was similar, the cost effectivity. And they suggest that DT-BAT for advanced heart failure in Duchenne patients should not be dismissed solely based on cost. What about the heart transplant in dystrophinopathies? As everybody could know, the dilated cardiomyopathy is constantly a progressive and evolving condition, and the widespread of the fibrosis causes dilated cardiomyopathy, and in the first episodes of heart failure are generally responsive to medical management and pharmacologic management, but in devolution there are intractable heart failure, and at this point the heart transplant remains an ultimate intervention to preserve life. But there are limitations and questions around this treatment option about the high operative risk related to the muscle impairment, and also doubts about the potential graft involvement secondary to underlying myopathy, and of course limitations of opacity of donors and myopathy impairment in devolution. So in the literature we could see some reports and isolated reports about heart transplant in Duchenne and Becker patients, and in Duchenne there are several isolated with different ages with successful results of heart transplant and more years to live. As recently we have a question: is heart transplant a real option in patients with Duchenne syndrome? And they present a case of an 18-year-old male with successful heart transplant after 47 months of Howell LVAD assistance. And about Becker disease, of course, there are different registries, as the USA registry with 15 Becker transplanted, and also the Spanish single center experience with 3 Becker patients with a median follow-up of 57 months, and they have similar survival, no higher complications. All the patients tolerated immunosuppressants, and there were no major complications during follow-up. So long-term clinical outcomes of heart transplant in selected dystrophinopathies are similar to idiopathic dilated cardiomyopathy, but we have to take special care and consideration in this population related with the doses of immunosuppressants to limit the muscle toxicity, and it's very important an early functional rehabilitation to get a good performance status as soon as possible. So a heart transplant, it could be an option treatment in patients with advanced dilated cardiomyopathy and poor muscle impairment, because a long-term prognosis in these patients are closely related to the possibility to be transplants. Oh, finally, this role dying with left ventricular assist device as destination therapy will have reports in the adult literature, and this is forever, unfortunately no ASAP, but it's crucial that any discussion regarding the clinical scenario of DT-BAT in pediatric patients include open dialogue about the end of life with patient and family. And at this point, the palliative care teams are crucial, play an important role, because they have to establish the goals of care and review the goals of care and the limitations of the DT-BAT, because the objective is live longer and with a better quality of life. But when the patient's quality of life is felt to be unacceptably low, it is reasonable to focus on confer measures, disconnecting the device and allowing the child to die. So finally, my conclusions, as my summary is that survival, neuromuscular function, and quality of life in dystrophinopathies are improving due to the glucocorticoid therapy and advances. Cardiac disease is an increasing cause of death in this population. Therefore, it's paramount to understand and to know how best to support this patient, not only with the pharmacological therapies, also with advanced heart failure therapies and ICDs. LVAD and heart transplant, ICD to 10, have similar rate of complication really compared to other pediatric populations. And LVAD is a treatment option as destination therapy, bridge to decision, and even bridge to transplant. The destination therapy BAT prolong life and improve quality of life, but this couldn't be in an urgent manner. It's a planned manner, case-by-case decision, and in a multidisciplinary approach. So the palliative care team is key role. So heart transplant may increase quality of life and life expectancy in selected patients. And in conclusion, although rarely used, advanced heart failures may be used effectively for end-stage dilated cardiomyopathy and may be considered carefully in selected patients with dystrophinopathies. Thank you very much for your attention.
Thanks, Carlos. This is a particularly difficult situation to address, the possibility of destination therapy and the costs of this therapy, and how much is the patient going to benefit from difficult and painful situations. So I guess your last conclusions are very good, very firm, and very difficult to solve. I think we should move on to the last speaker. Thanks, Carlos, again. And I give the microphone to Federico, so he will introduce the last talk.
Yeah. Hello, everybody. We will move to our last talk. This talk I would like to introduce both. My co-moderator is my friend Esteban López de Sá. Esteban López de Sá is the head of the coronary unit here at the Hospital La Paz, and he has a lot of experience related to what we will speak in a few minutes. And I would like to introduce also Dr. Enrique Balbacid. Enrique Balbacid is a pediatric cardiologist. Actually, he is an adult cardiologist working with us. He has a lot of experience, and I must say that we actually work side by side because we work together every day at the cath lab, side by side, really. So I'm anxious to hear what can he tell us about how can we extend the indications, whether is it possible or not, at the cath lab. So please, Enrique.
Okay, thank you, Federico. Thank you, Dr. Gareta, for inviting me to give this talk this afternoon. Good morning for all those Americans and for those participants still connected. Well, when I read the title of the talk, I was kind of surprised because it says, is there a place for intravascular assist devices? Well, we've been talking about all this afternoon. So I guess you wanted me to say something about percutaneously placed in children. And well, when you mean percutaneous, you may say that I have to find something that even a hemodynamist could put on a patient and make it work in the pediatric cath lab. So to be honest, I wasn't feeling comfortable enough with the title of this task. I decided to erase the word assist to begin with the idea and to the concept that sometimes the simplest device is the more useful for our patients. And these devices may try to create an interatrial shunt somehow to decompress the left atrium in the case of left ventricular dysfunction or the right atrium in the case of right ventricular dysfunction. And we aim to do this with different technologies, depending on the size and the weight of the child, of the patient. Like for example, in this case, in a very low weight infant or a big newborn, we did it with the placement of a stent in the interatrial septum before performing this aortic valvuloplasty, because sometimes this is the strategy that helps the patients the best. But sometimes if we have the opportunity in larger patients, like in this case, we can nowadays use this kind of plaster devices with a hole in the middle that creates a permanent shunt between both atria. And depending, as I said, on the weight and the age of the patient, we could start using it above 25 or 30 kilos because it needs a 10 French sheath from a venous access to create, to put this on these plates. And the smallest hole available at the moment is 8 millimeters. And this is the smallest one that has the CA approval for the moment. When creating this shunt in patients with Fontan pathways, like in this case with an extracardiac conduit of Fontan, we always have to be aware of the leakage. So we manage the situation with the creation of a shunt between the inferior vena cava and the atria with a tailored conduit we made with a covered stent like this, over which we put it on a small small coronary stent of 4 millimeters diameter, so it adopts itself a dog bone shape, like you can see here, when inflated spontaneously, so that we can create this communication between the Fontan pathway and the atria without leakage. But to continue with the main topic of the talk, with percutaneous assist devices in pediatric lab, and we have to look for something that is small, that is easy, and that is quick to put on a patient. So the answer at the moment is no. There's no percutaneous assist device at the moment approved for children use. And the main reasons why it's like that is mainly because of anatomical barriers, mainly talking the size of the patient, and also because of functional barriers, because of invasion of the working field. When we put on a patient, we put one of these percutaneous available devices for adults on a patient, it would sometimes disturb the place where we need to be working on, like in the aortic valve or the aortic arch, to show how the size of the patient is an issue with this
percutaneous procedures in advanced heart failure of our patients. I can show you this case where we did a coronary intervention in a patient after an atrial switch operation with severe ventricular dysfunction because of stenotic lesions in the left main coronary artery. And unfortunately, if you see the video, I wouldn't imagine how would we manage with an impeller or something like that crossing the aortic valve with all this small space here for all these things. So we had to do this on ECMO. This is another example of how these devices wouldn't be an option in our congenital patients with heart failure, in this case with right ventricular failure after rechange of right ventricle to pulmonary artery with severe dysfunction, where we put on a tricuspid valve in a ring, valve in ring procedure through jugular venous access in a patient. It wouldn't be possible with the actual impeller RP or with any other assist device that has to cross the tricuspid valve and the pulmonary valve. So we had to do this on ECMO again. But ideally, if we could choose the patients where we would be putting these devices on, we would take those with ventricular dysfunction or with low cardiac output syndrome or with a high risk of cardiac arrest while doing the catheterization. And these situations could happen before the patient is brought to the cath lab, like in a post-operative period with cardiogenic shock post-cardiotomy, or patients presenting with acute myocarditis, or maybe with acute rejection after heart transplant, or with severe congenital lesions or acquired lesions after a congenital heart condition is repaired. But sometimes, even if the patient is brought to the cath lab in good conditions, it could happen that during the cath lab this develops, like, well, for example, while performing aortic valvuloplasty or after any kind of cardiac arrest for whatever reason, while doing, although this is rarely done by us in our patients in coronary interventions, but sometimes it could happen that we may compress the coronaries while treating, for example, right ventricle to pulmonary arteries in our congenital patients. And why would we needing these devices in our day-to-day clinical practice? Well, for those patients in terms of avoiding cardiac arrest while doing these complicated or complex procedures in the cath lab, for helping us for optimal performance of the procedure, ameliorating recovery after these long interventions, or sometimes just to bridge the patient to the chirurgical theater to put him on ECMO and another assist device safer. Because sometimes the only opportunity we have to do this is, like in this case, when we brought this patient from home to do this aortic valvuloplasty done in the cath lab. This is a small infant of 2 or 3 months, just 1 or 2 months old, a small infant, where just after doing this aortogram for performing this aortic valvuloplasty, he developed ventricular fibrillation, so he started giving him cardiac massage, and we had to put him on ECMO in the cath lab, and then he underwent a ROS procedure. So for avoiding these situations, it would be the ideal patients. But what we could be doing this in the future? Well, we have different strategies for, depending on the assistance of the right or the left ventricle. If we, for the right ventricle, we have the impeller RP, and also the tandem heart technology adopted for the right assistance. And for the left ventricle, we have all technologies like the balloon pumping, the impeller family, tandem heart technology, and probably in the future the heart-made percutaneous heart pump. This is a schematic resume of left ventricle assist technologies. The letter A represents the pumping technology of the balloon. Letter B represents the continuous axial flow of the impeller family, and letter C represents the centrifugal continuous flow of the tandem heart technology. So, to say something about the aortic balloon pumping, you all know how this works by increasing the diastolic pressure in the aortic root, and thus increasing the coronary flow and decreasing the afterload of the left ventricle while in systole by deflection. but it already needs an arterial access of a relatively large size of 80 French and helps us with 1 liter per minute. So we will be putting in on patients of about 20 or 25 kilos, which is not that big, but not that small, let's say. But if we go back to 1997, we will walk to the past, there used to be once upon a time, even technology for much smaller patients, as we can find in this work. There, it was described that the aortic balloon pumping technology could work in small children, starting from 3 kilos or more or less even big newborns, because it was demonstrated that the size of the balloon, it had only to be 50 to 60% of the stroke volume of the patient, and those small balloons could be mounted on small catheters of 4.5 French. So we could be starting, it would have been possible to be starting with them in small infants. But the truth is this technology was slowly abandoned, and this is one of the last reports on its use on children with different kind of diseases with left ventricular dysfunction, with relatively good results of almost 70% of survival. But the weakness of this technology in pediatric population had to be with different reasons, like for example, that the ECMO became more and more available for those days, and also because the hemodynamic benefit of the pumping balloon in children is less effective because of the aortic elasticity, because the high rate proper of small children or infants sometimes make it difficult to coordinate inflation and deflation with the electrocardiogram because of low systemic resistances, and also because pumping balloon doesn't really help in right heart failure, since the right coronary artery doesn't depend that much on diastolic perfusion as the left main does. To continue with tandem heart technology, you know this is a continuous flow, centrifugal continuous flow technology that takes the blood from the left atrium through a transeptal access, which is something incredible for us because it allows us to work on left-sided structures like aortic arch or aortic valve, but it needs nowadays, still needs a 20 French venous access, and it's approved for its use up to 30 days and helps between, depending on the aortic cannula, between 3.5 to 5 liters of cardiac output. But if we go back again to the past, to 2005, we can see that these authors of this bench testing and on this bench work with the same technology in smaller patients, and they demonstrated that this technology could also work in small infants or even newborns with a French venous and arterial cannula placed on the neck, and giving us the possibility of starting with femoral access above 35 kilos, which is mainly what we will be doing now with adults. But this technology, although developed, never saw the light in the market. They even gave us these images how to put it on the neck for small infants with the jugular and carotid cannula, and they describe also the possibility of doing this through a transhepatic and transeptal access to the left atrium. But as I said, even if this technology was developed and the bench testing work was done, it never saw the light in a commercialized. For patients with the need of right ventricle assistance, we recently saw this new cannula that has a dual lumen path. So with just one big jugular venous access, we could assist the right ventricle by placing it in the pulmonary artery. But as I said, the size is again the big main problem, because it needs a very, very long, very large jugular vein access of 29 French. To continue with the family of the impelling devices, the smallest one, the one we will be using in our children, you'll know this is a continuous axial flow device that is placed across the aortic valve, thus helping adults when doing complex percutaneous coronary interventions. But for instance, it wouldn't be an option for us while doing, for example, an aortic valvuloplasty or treating the aortic arch. And it already needs 12 French arterial access, which means that for us it would be it would start being an option in patients above 30 or 35 kilos as well. It is approved only for its use up to 5 days. This is one of our experience with the Impella device in a young congenital adult patients. Adult patient with presenting to the emergency department with cardiogenic shock because we think of acute myocarditis and severe left ventricle dysfunction and phantom failure. We put him on this Impella device, and once the left ventricle had recovered, short after, we still needed for him to improve finally, as I said before, this creation of an interarterial shunt. So the phantom pathway, let's say, was fenestrated in a word, so put him stand on the connection of the atriopulmonary fountain. He spent, I think, at least 6 months in the coronary unit for him for recovery. He had hemofiltration for 3 months, and he needed also 3 more months of hemodialysis to recover finally, but he's doing well without severe sequelae. And we also have this technology available for right ventricle. The Impella RP is the only percutaneous assist device approved for helping right ventricle. This is a device that needs venous access of 22 French, which is comparable to the size of the access we need to put, for example, a melody valve in a pulmonary position. So this size is something the pediatric hemodynamics are, let's say, it's something common for us to think about this size of access. So which means we might be putting this on a patient of above 25 kilos, for example. It helps with 4 liters per minute. This is how it looks like on fluoroscopy, and we can use, as described, both technologies on the left and the right sides if needed. One of the latest reports on the outcomes of this Impella RP device is this one that has good results in terms of survival of almost 75% at 30 days, and it shows how after weaning the patient of the device, the cardiac output still remains stable. And though the heart-made percutaneous heart pump is not available anymore because problems with the designs of the trials that were thought to demonstrate its benefits were stopped, this technology is interesting because it's based on a self-expanding cannula that still needs a 13 or 14 French access in the artery, but it develops, it displays up to, because it's self-expanding, to a 20 French device, the aortic annulus. So this is one of the ideas that could help this percutaneous technology become smaller because of self-expanding material. So to finish with this talk, my take-home messages are that today, the truth is that we have no pediatric assist devices specifically designed for our children. All technologies, as I said, that were developed could be, for example, rediscovered or re-commercialized. But since our patients are not patients with coronary necessities, let's say, sometimes we will need new technologies for new strategies for new patients. And they need different things because we are not performing Chinese coronary interventions many of the times, and the size, as I said and as I showed you, is the big main problem to overcome. Thank you.
Thank you very much, Enrique. A very nice talk, and you have done a very good review about all the devices that are available for percutaneous assist of the ventricle. But I don't know, what I feel is obviously the size of the patients is the most important barrier to implant these devices. If the devices were smaller, probably you agree with me that you use it more than you will use it more than we are using them right now, no? But there are new devices coming, IVAD connected to the console of intra-aortic balloon pump, and what I think is that probably we were I am adult cardiologist, so I'm most of the times when we work in the coronary care unit and we work in the cath lab, we are alone, and we are more prone to use this kind of devices. I think you, in your life, you are always helped by surgeons, and surgeons act quite quickly implanting ECMOs and assist devices in pediatric patients. So probably there is more space for bigger children. I mean, 20, 30 kilograms to use this percutaneous device more than what are using right now in the pediatric scenario. What do you think about?
Yes, I think the 20, 25, 30 kilo might be the barrier where we be feeling comfortable with these kind of devices. Even we don't have any CE approval for any of its use on children in Europe, but the size would be more or less that size. As you said, while having ECMO available 24 hours and a good surgeons and a good surgical team that will be helping us when needed, is less probable that we will be putting this on a patient. But sometimes you can't predict what is going to happen in the cath lab, and you need to do it by yourself. You need to do it quick, and you need to make it easy. So sometimes we might be feeling kind of more comfortable while having these backwards in our cath lab, but as I said, the technology was available once, so it's about to retake and rethink about using the same things, because it used to work at one moment.
And even for me, what is strange is because they were available intra-aortic balloon pump for children, and
yes.
Really they were. I agree with you that it doesn't work the same as an aorta, because it's more rigid, and children aorta is more elastic, and contrapulsation is less effective in children. But we use it a lot, more than 100 intra-aortic balloon pumps a year, and I see that, well, you don't trust in them. I mean, pediatric people do not trust in them.
Well, and neither the other people, because it came to indication for the Americans and a class 3 indication for the European guidelines in the setting of acute myocardial infarction. So not even the adult people trust on it anymore in the acute myocardial infarction context. But well, we ask ourselves sometimes, why don't we have this available for children? And the truth is, one of the big main reasons is that it's not commercialized anymore. And at the time it was being developed, this technology, ECMO, became more and more available. So I think the better result with the ECMO for those patients made it not that easy to find.
Well, I think we agree in all the things that we are talking about. It's just to discuss. But you know, you also know that the intra-aortic balloon pump is the most employed device in Europe and in the States. Even it's class 3 right now as routine in cardiogenic shock in acute myocardial infarction. But I think there's not, the information that we have is very few. You showed all the studies that are published about this. The evidence is very few. And well, but I think there is a great field to improve, and probably we will have new devices in the future. Thank you very much, Kike. It was a nice presentation.
Thank you to all.
Okay, thank you very much. I think we are short of time. Thank you very much to all of you. I will give the last word to my colleague and friend, Luis Guerreta, so I think he will close the meeting.
Estamos aquí con vida. Sí. Hello to all of you. I want to thank especially everyone who has joined us and who has stayed in the meeting. I have seen a lot of participants and a lot of people staying for all these talks that right here in Spain is getting to be evening, and after a long day, there have been many people who have been able to stand in front of the computer for 2.5 hours, and I want to thank all of them. And I want to thank all the speakers that have joined us. And I want to thank every one of you who have made up a presentation, and thank to all of you from Spain who have spoken in English, so we could have this as an international meeting, and that our colleagues that have been so kind to join can listen to our talks, which is very good. We can listen to them and they can listen to us. And I think it has been a very good event, in my opinion. And I'm very pleased that I have received so many participants for the meeting. Thanks a lot, and we'll see you next time, whenever it will be.